I am new at this whole Zoom presentation thing, so please bear with me if there are any technical difficulties. I'm going to try to share my screen now, and then we will get into the presentation. Okay, let me make sure my video is still on. Okay.
There we go.
There we go. Okay. Everything good? You can see it?
Yes, we can.
Thank you. Okay, so today's presentation is to address specifically what is lymphedema. Today's session is purely informative and not necessarily medical advice. Always speak to your physician regarding specific questions, medical advice, talk to your therapist. But basically, I would like to educate everybody on a topic that I'm really passionate about, and that is lymphedema. So when we say lymphedema, most people think about pulling off compression stockings and everything just, seems like it's going to be very uncomfortable and tight, when the reality of treatment for lymphedema does not have to be like this. Rehab can be fun. So this is a picture of one of my patients who is a breast cancer survivor. And although she is not pictured wearing her compression wear here, she actually was being sized and fitted for it the day that we took this picture. But this is my rehab facility. We use the red cord system to provide neuromuscular reeducation for orthopedic patients, breast cancer, any sort of cancer rehab, really anybody who needs physical therapy. But I have found that with the cancer rehabilitation population, this system works as best as I've ever seen and kind of helping to rehab the whole system. So it can be fun. What I want to do to start off is just go into a little bit of an education about the anatomy of the lymphatic system. It's a system that I will say most healthcare providers are not as familiar with as all of us lymphedema therapists would like. They get about maybe 20 to 60 minutes of information on the lymphatic system in medical school. So really it's kind of providers with more advanced education. It's kind of our role and responsibility to help educate others about the lymphatic system. So on the right-hand side of the screen is a diagram depicting where all of our lymph nodes and vessels are throughout the system. Our lymphatic system has really two basic things that it does. The first is it helps transport our immune cells, and the second is that it helps clean up metabolic waste. So we are going to go into more detail on all of this, but I just want you to get a general sense of kind of the scope of our lymphatic system. On this diagram, all of the green lines are our lymphatic vessels, all of the dots are our lymphatic nodes, and then everything else is depicting our organs that are very tantamount to the lymphatic system. So just to kind of break it down for us, on the smallest scale of our lymphatic system are all of that fluid, which consists of metabolic waste, water, blood cells. We can kind of go into more detail on that as we go through the presentation. But everything that gets taken up by the lymphatic system and transported by the lymphatic system on the smallest scale goes through our capillaries. Then everything flows from this high pressure area in our capillary beds to low pressure areas. That would be our lymphatic vessels, and then eventually lymphatic trunks, and then lymphatic ducts. So everything in our system is always set up to go from high pressure areas to low pressure areas. Our lymphatic system is pretty cool insofar as it has automaticity, just like the heart. There's smooth muscle in the walls of our lymphatic vessels that contract on their own. The system has a series of one-way valves to prevent backflow. And the system is also aided by the act of breathing and muscle pump to help move all of this lymphatic fluid through our bodies. It eventually gets dumped kind of into the circulatory system, which we'll also go into. It gets processed by our kidneys, and then we urinate out any of this metabolic waste. So also in our lymphatic system, we discuss the lymph nodes. Nodes themselves, which people may be a little bit more familiar with, are pretty small in size, typically 1 to 25 millimeters in size. If they kind of grow beyond that, we know maybe there's a little bit of a backup or an issue with a lymph node in particular. Their job is to filter and purify lymphatic fluid before it reaches the venous system. So you can picture these nodes, they're like tiny little kidneys, and they help process all of our lymphatic fluid. They are vascularized. So in order to do their work, they need blood flow from our arterial system, oxygenated blood flow, and then that deoxygenated blood flows back out via the lymph node vein. If we're going to discuss the anatomy of the lymphatic system, I also felt that it was really important to talk about the diaphragm. So the diaphragm is a muscle that helps with breathing, right? Inspiration, exhalation, and the thoracic duct, which is the major highway, carries all of our lymphatic fluid up to the venous angles. You can kind of see at the top of the screen where the thoracic duct, which is the big green vessel, ties into those larger blue vessels. That's where all of our lymphatic system eventually gets dumped into the circulatory system. In order to help that muscle pump for the fluid to flow up towards our subclavian veins via that thoracic duct, the diaphragm is the major muscle that is able to assist our fluid to do what it needs to do. So we actually, at the end of the presentation, are going to go through an exercise for diaphragmatic breathing, because it's one of the easiest things that we can do that really helps move our lymphatic fluid along in our system and prevent any sort of backflow or swelling. Now that we covered a little bit of the basic anatomy, what exactly is lymphedema? So lymphedema is swelling that occurs when our lymphatic fluid builds up in what we call interstitial space. So interstitial space is anything in our system that is in between muscle, adipose tissue, blood vessels, nerves. Really, it's that kind of void space that, as a fun fact, actually accounts for about 16% of a human's body weight. And that lymphatic fluid, as I said earlier, consists of plasma proteins, extravascular blood cells, excess water, and kind of this protein-rich organ tissue byproduct. So what that means, that byproduct, is if we, let's just say as an example, have a small localized infection, our lymphatic system will transport helper cells to kind of help clean up any bacteria that has come into that area. And then as that bacteria is broken down, the byproduct that's left is protein-rich metabolic waste. So it's just kind of a bunch of broken down bonded proteins that need to be cleared from our system because we don't really need it anymore. So that is kind of what lymphedema truly is. It's a excess of buildup of lymphatic fluid in our interstitial space that causes, swelling, heaviness, discomfort in an area. So there are two main causes for this buildup. The first is the transport capacity of the system is reduced. So what that means is, for example, a sentinel node biopsy. We're born with a fixed amount of lymph nodes in our system. If any of those lymph nodes are removed, we are now working with a reduced transport capacity. So let's say I have 20 lymph nodes in my armpit, and a sentinel node biopsy can remove anywhere from 1 to 3 of those lymph nodes. And in this case, 3 nodes were removed. Now moving forward, I will have 17 nodes in that armpit to help filter out the same amount or more, depending on what's going on with my body, of lymphatic fluid on a daily basis. So that would be if your transport capacity is reduced. The second reason for lymphedema, main reason, would be if your lymphatic fluid, so all of that fluid in your interstitial space, has overwhelmed your existing transport capacity. So like in a normal system, a quote unquote normal healthy system, if let's say I fall and really majorly sprain my ankle, my system is going to be overwhelmed with lymphatic fluid that it will not be able to clear again until my muscle pump returns, until I'm walking more normally again and all of the muscles in my leg are working as they should be in order to help clear that fluid. Okay, so really there's two main reasons why lymphatic fluid would build up in between all of that interstitial space. As a fun fact, our normal daily lymphatic transport is about 10%, only 10% of our actual capacity to transport lymphatic fluid. So we have 90% more space in our lymphatic vessels and nodes to work through lymphatic fluid and prevent a buildup of that fluid or swelling, inflammation. Okay, so examples of reduced transport capacity, to go into a little bit more detail on this. One example would be something called primary lymphedema, where somebody is born with less lymph nodes or vessels than would be a normal range. Everybody is born with a different amount of lymph nodes in their drainage areas, but everybody is considered like who has normal amount of lymph nodes is still within a range or a tolerance. So if somebody is born with lymph nodes that are under the lower end of that range, it's considered primary lymphedema. So they will always be at risk for their system being overwhelmed with lymphatic fluid. Another example of reduced transport capacity would be if you have your lymph nodes removed. If there is cancer or an infection or an alternative reason to remove lymph nodes in a certain area, head and neck, axilla, inguinal nodes, abdominal nodes, nodes in the back of the knees, you would also have a reduced transport capacity. Radiation, multiple orthopedic surgeries will also damage lymphatic vessels and any nodes that the radiation or the orthopedic surgeries have affected. Unfortunately, our lymphatic system is not really great at rebuilding itself, and we cannot regenerate lymph nodes. There is some amount of regeneration of lymphatic vessels or anastomoses. So lymphatic vessels can kind of grow around an area that is possibly damaged or has scar tissue, but our bodies are not as good at doing that as our bodies are at regenerating muscle tissue or skin tissue, for example. Other reasons why we would have a reduced transport capacity: history of infection to an area can damage lymph nodes and vessels, and they will have a really hard time recovering. There could be a mass, whether it's benign or cancerous, blocking lymph nodes and vessels. And somebody could have a history of a DVT. So if a patient has a blood clot in their leg and the blood clot gets broken up with medication, it still leaves kind of a long-lasting effect on the lymphatic system. It really doesn't take a ton of pressure to cause a blockage in our lymphatic system. It's really kind of anything more than 40 millimeters of mercury can start to compress our lymphatic vessels. Some examples of increased fluid volume in a kind of normal system that doesn't have a reduced transport capacity, where you would see lymphedema or a buildup in excess of fluid, acute injury, surgeries, acute infection, acute DVT, congestive heart failure, anything that really causes an acute, quick, large amount of fluid to build up quickly where our systems cannot clear it. So who is at risk for lymphedema? Anyone who fits the criteria that we just discussed. Cancer patients are at a higher risk for lymphedema than the majority of our patient population. Cancer patients, people with venous insufficiency who are prone to swelling, just sort of backing up in their legs because their veins are not working as ideally as we would like them to be. And then that venous fluid can press on the lymphatic vessels, causing kind of more firmer swelling in patients' legs. People with congestive heart failure, where their heart has a really hard time pumping the fluid that's in the system, their system will shunt fluid to their hands or their legs. And so we see lymphedema in that patient population as well. And any patient in general who is of a more obese BMI is at a higher risk for lymphedema. So our cancer population, especially, studies have shown that individuals with a body mass index of 30 or higher at the time of diagnosis were 3.6 times more likely to develop lymphedema. Weight gain after diagnosis was not shown to be related. So in general, always good to keep a lower BMI. 30 or under is, under 30 is ideal, under 25, even more ideal. So epidemiology among cancer patients: lymphedema can occur within days post-op or radiation for up to 30 years after treatment. This is specifically for breast cancer. Overall risk for all types of cancer for a patient receiving a diagnosis of lymphedema is 15.5%. 80% of those patients are diagnosed 3 years post-op, and the remainder are diagnosed at 1% per year. Okay, so there is certainly a risk of lymphedema, especially among cancer patients. How would I know if I had lymphedema? So I get asked this a lot by patients pre-operatively doing patient education prior to, let's say, a mastectomy, or axillary node dissection. We go into education about lymphedema, and they say, well, how would I know if I had it? So you would feel typically heaviness in a limb, or possibly heaviness in your face or head and neck. If you had any sort of head and neck cancer, you would notice decreased visualization or of veins or tendons. So you can see the picture with the woman's hands on the bottom right of the screen. You know, you can see her veins and tendons in her left hand, but it's much harder to visualize that in her right hand. Okay, so clothes would fit tighter on the affected limb. A lot of breast cancer survivors, I hear kind of like tightness or just achiness, discomfort in their upper back or arm or shoulder, maybe even discomfort in the neck in breast cancer population. So what do I do if I think that I have lymphedema? Please speak with your primary care physician, oncologist, gynecologist, and request a referral to a certified lymphedema therapist. Once you have to be your own advocate, because unfortunately, you know, not all physicians are aware of lymphedema, and, you know, oncologists, radiation oncologists, they are focused on getting cancer out of the body. So that is their main tunnel vision, is just get that cancer out. And then afterwards, you know, sometimes they're not as aware of kind of what is going on after the cancer is removed from someone's system. So that's where we come into play. That's where the lymphedema therapist plays a large role in a cancer survivor's life, because our job at that point is to give all survivors back their quality of life. And lymphedema is a huge component of that. So kind of dealing with swelling, addressing swelling, and the achiness that could kind of go along with it. That's what we want to do. We want to get it, nip it as soon as we can, and work on self-management. So ultimately, you would likely benefit from a referral to a certified lymphedema therapist. The Lymphology Association of North America recommends that therapists providing CDT have completed at least 135 hours of training. So that's any physical therapist or occupational therapist who has their certified lymphedema therapist. Additional education would be kind of who you want to move on in the next phase with. Once you present to your physician and let them know, hey, I feel some heaviness in my arm or my leg or my head and neck, just so you are aware, they might move on and want to do some additional diagnostic work to demonstrate that it is or isn't lymphedema. They may take measurements. They're going to take your subjective information, objective information. They may look for, you know, if you have a loss of like wrinkling in the skin, if your skin is firm when you push down on it, if there's what we call pitting edema, which we'll go into in some of the future slides. They may also look towards some imaging, so lymphoscintigraphy. The picture on the screen is an example of what lymphoscintigraphy looks like. Dye is injected into your lymphatic system, and then your system is scanned, and wherever the dye is taken up by, that's a functioning lymphatic system. This picture is an example of lymphoscintigraphy used to locate a sentinel node for a cancerous tumor in a patient's breast. They may want to look at MRI imaging, CT scan, or an ultrasound. So once your physician has said, yes, I feel this is lymphedema, there are two types of classification systems. The first is the common terminology criteria for adverse events. And this criteria works with percentage of limb discrepancy. So a grade 1 classification would be 5 to 10% discrepancy in volume of the affected limb versus the unaffected limb. Grade 2 would be 10 to 30% discrepancy. Grade 3, more than 30%. Grade 4 would be a progression to malignancy. So it would be a lymphedema that would be basically disabling. The most frequently used symptom for classification is the International Society of Lymphology. So this is what I use. And we classify lymphedema from stage 0 to stage 3. Stage 0 is the latent phase. So any patient who has a reduction in transport capacity, like we talked about before, so that they either have a sentinel node, a mastectomy, and a sentinel node biopsy, or some sort of axillary node dissection, where a certain percentage of axillary nodes are removed, that patient is at risk for lymphedema, and we would consider that patient a stage 0. From there, it would progress to stage 1, where there's some swelling in the limb, but the limb, if the limb is elevated, that swelling drains out of the limb. Stage 2, the swelling does not drain out of the limb and it becomes pitting. So when I say pitting, I mean, if you press your finger down into your hand, your fingerprint stays for more than a second. So there are certain classifications of pitting edema as well. The firmer and firmer and firmer the swelling gets, the less you can actually press your finger down, and the more the skin is just hard, and the swelling really does not come out at all, and maybe lobules would even start to form in the affected limb. That's as we progress towards stage 3 or severe lymphedema. So just so I'm a visual person, but just so you can kind of see and visualize what the stages look like for upper extremity and lower extremity lymphedema. So once you receive the diagnosis of lymphedema, how is it treated? So the gold standard is called complete decongestive therapy. That's what I do. And that's what all certified lymphedema therapists, the service that they will provide is CDT. Other options are surgical options such as the lymphovenous anastomoses, a lymph node transfer or bulk tissue removal. So if somebody is, let's say, in that stage 3 lymphedema, a plastic surgeon might go in and just remove a ton of adipose tissue and do a liposuction, essentially just to kind of get a bunch of tissue out of the limb and hope that that pressure of adipose tissue and all of the kind of swelling that comes along with it removes pressure from the lymphatic vessels and nodes, and the system can start working again. The other thing that I didn't put on here is some cardiologists or primary care physicians will also give their patients diuretics. So a diuretic is like a water pill, some people call it, and it will help remove some of the bulk amount of water from somebody's system, but it doesn't necessarily remove the protein-rich fluid in somebody's system. So in some cases, placing a patient on a diuretic actually kind of makes the lymphedema worse because the protein concentration increases, and then that protein wants to draw more and more and more fluid to it. So it's important, if you do have a diagnosis of lymphedema and somebody does want to put you on a water pill, to make sure that you're also in some type of complete decongestive therapy to get the protein out of the limb as well. Complete decongestive therapy. So this is the gold standard at this time for removing excess lymphatic fluid from that interstitial space. It consists of 2 phases. The first phase is a decongestive phase, which lasts 2 to 8 weeks. The second phase is the maintenance phase, where it's a self-maintenance phase, and that's at the end of the decongestive phase for life. So it's important that you get a good foothold in the decongestive phase because you're going to take all of that information with you, and it's going to give you your optimal quality of life, your optimal ability to exercise, hang out with your family, do your work, et cetera, et cetera. So the first phase is if somebody is a stage 1 or more classification, we would consider short stretch bandaging. So wrapping somebody's limb, as you can see in this picture, that's a good example of short stretch bandaging. It's layers of bandages that actually don't have a ton of stretch to them. It's almost acts as a soft cast. You would go to your therapist every day for bandaging. So the gold standard is that patients are wrapped 5 days per week. And it typically lasts 1 to 2 weeks before all that fluid is cleared from the limb. So it really needs to be a good focus in life by taking 2 weeks to really come to physical therapy or occupational therapy every single day, have your limb bandaged, get that swelling out of there, so you can kind of move on to the maintenance phase. Also part of the decongestive phase is manual lymphatic drainage. So it's a massage that is the therapist's hand on working on the affected limb to drain that limb to other areas of the lymphatic system that are not damaged and are operating well. So that also will go into self-management. So I always like to educate family members and the patient and demonstrate multiple times how to do self-manual lymphatic drainage, because that is something that you're going to want to use as needed forever and ever. Diaphragmatic breathing, like we talked about, super important. That muscle pump pushing on your thoracic duct really helps kind of move that lymphatic fluid into your venous system. Proper skin and nail care, we want to avoid infections because that can increase the risk of swelling in your affected limb. So just making sure that you attend to cuts immediately. We'll talk a little bit more about skin and nail care as we kind of move on in the presentation. And then, of course, patient education. Maintenance phase, getting fitted for a daily compression garment as needed, educating patient in self-manual lymphatic drainage, like we talked about, skin and nail care, recognizing your precautions as somebody who has lymphedema. So we'll also go into that, but basically avoid blood pressure in the affected limb, avoid restrictive garments on the affected limb, avoid needle sticks on the affected limb. If you're getting your COVID vaccine, by all means, if you have 2 affected arms, whether you've had breast cancer, radiation, axillary node dissection, or lymph nodes removed on the left and the right side, ask the person who's giving you the shot to put it in your leg. So we have seen a lot of swelling with the COVID vaccine, and they are definitely allowed to give you the injection in your quad. So please make sure to ask for it. Maintenance phase, exercise with your compression garments on, making sure that you get a good rest and self-managing all of your symptoms. So fun fact, this is my son, getting good rest. CDC recommends adults 18 to 60 get at least 7 hours of sleep per night. Adults 61 to 64 get 7 to 9 hours, and 65 plus 7 to 8 hours. So get your rest. Again, this is for people who have a more visual sense of, this is on the left side is the decongestive phase. On the right side is the maintenance phase of complete decongestive therapy. So these are just visual depictions of everything that we discussed. To go into a little bit more detail about compression. So compression is a huge component of CDT. Typically, we want to move patients as quickly as possible into their daily compression wear. whether it be a thigh high, a knee high, a compression sleeve, a compression glove, a gauntlet, compression bra, you know, daily compression wear is our ultimate goal, and we want one that is well fitting. So once we move past that gold standard phase of short stretch bandaging, we want to move quickly into deciding what type of compression wear works for each patient. There are custom compression wear versus off the shelf, flat knit versus circular knit. There's compression classes that we want to look at. And, you know, also the option for Velcro garments. If somebody is just not able to get into the clinic 5 days a week for short stretch bandaging, I will always put them in the direction of Velcro garments so they can decongest the limb on their own. Not as effective as short stretch bandaging, but it does still get the job done. There are garments that you can wear at night. There are garments for head and neck lymphedema, upper extremity, breast, lateral chest wall, abdominal, genital lymphedema, and lower extremity lymphedema. So what I will say is probably the trickiest lymphedema that I deal with is swelling in the breast and the lateral chest wall. There are garments that work very well for that area. And that area is going to be best served with manual lymphatic drainage and doing that properly as well. And if anybody has any questions about that more specifically, you can ask me now or at the end. So manual lymphatic drainage, gold standard. We want to move fluid away from the affected limb and the affected lymph node area, and we want to transport that fluid to areas that are operating normally, that don't have a reduced transport capacity. So for example, if my left armpit had lymph nodes removed from it, my manual lymphatic drainage would be to transport the fluid in my left arm to my right armpit or the nodes on the outside of my left groin. We also use the deep abdominal system a lot for manual lymphatic drainage. Alternative option to the massage is using intermittent pneumatic compression pumps. This is a picture of a pump from Tactile Medical. I am not endorsing them and I don't get anything from them, but I think they have some of the best pumps at this time on the market because they drain the abdomen, lateral chest wall, breast, and the limb. Same thing if somebody they actually have a pump for head and neck lymphedema as well, and they'll drain the abdomen and the head and neck region. So pumps are also a great way to self-manage. I still have found, and evidence has still shown us, that actually doing the massage is still more productive than the pump, but the pump is probably in most cases more productive than somebody doing self-manual lymphatic drainage. So it is a good option for people. Proper skin and nail care. Want to make sure that you have good moisturizer, lotion on your skin at all times. Make sure that it's fragrance free, it doesn't have any dyes in it. I really like Eucerin or anything that is similar to Eucerin. Be sure to not have your cuticles clipped because that can provide a tiny little portal for infection. Avoid hot tubs. Please tend immediately to wounds. If you feel that there is an infection, contact your doctor right away. Signs and symptoms of an infection. The area around the wound would be pink. If you press on it, it would stay pink. You wouldn't see that blanching, or it wouldn't turn white and then turn pink again. It would just kind of stay pink. It would be warm, red, swollen, and there might be pink streaking in the direction of your lymph nodes. And of course, a systemic fever and just feeling really sluggish is also a sign or symptom of an infection, and that infection is progressing. So please follow up with your physician immediately if any of these signs or symptoms are happening in your body. Exercise. Let's picture my husband. Exercise. So that can be a whole nother presentation in and of itself. You want to make sure that you're always exercising with your recommended compression wear. You're exercising per your physician or physical therapist protocol or occupational therapist protocol. Just be really mindful post-operatively. A lot of physicians and oncologists and plastic surgeons really want to keep your heart rate low in a certain range to make sure that your blood supply to your tissue is still good. So just be mindful of those types of protocols. Any of the more intensive procedures like the deep flap or lat flap reconstruction, that those all have their own protocols onto themselves. So you definitely want to adhere to that just to maximize your strength and stability in the future. I would avoid exercising in extreme heat. I know the summers get really humid here. So that's a time where you would probably want to try to exercise inside and get your cardio and your strength training in, which are highly recommended forms of exercise for cancer survivors. I would definitely avoid high intensity exercise in the heat. Anything that's going to produce a ton of inflammation, you want to try to avoid. Pain-free is the way to be. Absolutely always want to be pain-free when you're exercising. Start easy, build up. Keep in mind, you can be sore for up to 48 hours after trying something new. Okay, so that's delayed onset muscle soreness. So if you go for a 5-mile hike on Saturday and on Monday, like your back's bothering you or your arm feels heavy, that could be from that hike on Saturday. So just keep those types of things in mind. There are some contraindications to complete decongestive therapy. That's if somebody has an active infection or an acute DVT or PE. So that's a deep vein thrombosis or a pulmonary embolism, blood clots in the lungs or the legs or the arm. Acute exacerbation of congestive heart failure. Patient just does not want to go through CDT. Some relative contraindications are active cancer, congestive heart failure. So that'd be chronic congestive heart failure that's managed, paralysis, decreased sensation, or diabetes. So you would want to follow up with your physician and just get clearance if you have any of those issues. Can anything be done to prevent lymphedema? So there is no current evidence-based protocol to prevent lymphedema, but if you are at risk, you can do your best to maintain proper skin and nail care, stick to a low inflammatory diet, avoid a ton of alcohol. Mediterranean diet is the most evidence-based diet that keeps inflammation at a minimum. Avoid needle sticks and BP, blood pressure in the affected limb. So we talked about that, especially with like, if anybody is looking into the COVID vaccine, just make sure you ask to get it in your leg. Avoid aggressive massage to the affected quadrant. I have had several patients who did not have any swelling in their arm. They were breast cancer survivors. 3 years later, they got a massage, and a few weeks out or a few days after that, their arm started to swell, and they couldn't figure out what was going on. And then when we talked about their history, you know, I asked about, have you gotten a massage recently? And they had, and it was a more aggressive massage. So just be aware of that. It's not that you can't get a massage, but maybe avoid aggressive massages to your affected upper quadrant, and just, you know, stick with the recommendations of your certified lymphedema therapist on that. Again, don't clip the cuticles, portal for infection, aim for 150 minutes of cardiovascular exercise per week. That's the recommendation of the American College of Cardiology. Avoid tight or restrictive clothing on the affected side. Maybe look for a fanny pack or a backpack to equally distribute weight. Avoid wearing bras with an underwire. That's for breast cancer patients. And work on your diaphragmatic breathing. This is a little slide on the future of lymphedema interventions. So I had a workshop, I went to a workshop a few weeks ago, and one of the physicians was presenting on this lymphovenous anastomoses. I think it's pretty cool. They go in and directly reroute a blocked lymphatic vessel to a vein, and it actually is showing really good efficacy. So I'm hopeful for our future, and hopefully this becomes a little bit more renowned. Right now, I know of, I think, maybe 2 places that have it, and I think it's Sloan Kettering and the Mayo Clinic. So pretty cool stuff on the horizon. And to end our presentation today, I wanted to go through a little exercise of diaphragmatic or belly breathing. This is something everybody can do. I suggest starting with just 2 minutes a day of working on your belly breathing and then building up from there. Another great way to focus on belly breathing and moving your diaphragm is to do yoga. So yoga flow always has breathing worked into it, and that feeling of relaxation. If anybody's ever done yoga after doing a yoga, doing your yoga practice, is really that all of that lymphatic fluid has kind of drained out of your system, and your parasympathetic nervous system that rests and digests is kind of taking over. Your vagus nerve and your thoracic duct both go through your diaphragm. Vagus nerve is responsible for parasympathetic response. So once that nerve is activated, you are going into that rest and digest mode. And then your thoracic duct, obviously, like we discussed, is responsible for moving that lymphatic fluid into your circulatory system. So a little exercise is in the seated position. You can place one hand on your chest, one hand on your low belly. Take an inhale through your nose. Exhale through your mouth. And the hand that's on your low belly is the one that should gently rise and fall. That's how you know you're doing proper diaphragmatic breathing. At the end of this slide, I'm going to pull up a video of diaphragmatic or breathing using accessory muscles and then breathing using the diaphragm, just so everybody can see the difference. There's also a link on here for a balloon exercise that I think I found to be really useful in finding the diaphragm and managing pressure in your abdomen. So I'm going to send, it's a little bit of a longer video. And so if people have time on their own, they can play it and try to practice that exercise. And for now, thank you. I'm going to go into the diaphragmatic breathing video. Okay, so this is an example of using accessory breathing muscles. So if everybody can kind of see, her chest is moving up and down versus low belly rising and falling.